Good evening, class. Welcome back. This is PARM 2223, Spring 2020, Unit 10, Class Autonomic Dysreflexia, Part 2. I'm trying to get my radio voice down. It's not quite working so well, so bear with me. But anyway, so here we are talking about autonomic dysreflexia, and in Part 2, we're actually not that far from the finish line of this lecture. Let's move right along. So ask yourself to give yourself a good question, and the question is there anything that we're doing in EMS when we transport patients with autonomic dysreflexia that might actually exacerbate it or cause problems? So take a look at this picture. We've already discussed how catheters, GU problems is a major, almost 80 or more than 80% of the etiology of exacerbations of autonomic dysreflexia. So take a look at this. Does this look normal? What, have you seen this before? Now at first glance you might like, oh yeah, this is probably okay, until you realize that the catheter bag is above the bladder. So what happens as the patient expels urine, it cannot empty into the bag. This causes a backup of urine into the bladder, which can in turn cause distension, UTIs, pain and discomfort, any number of noxious stimuli that can precipitate AD. So of course the big clue is, if you're transporting a patient, whether on a gurney or whatever, is make sure this is lower than the patient's bladder so it can drain fully. And of course, if this bag is completely full, empty it. Take a look at these well-made, excellent examples of gurneys. So I actually, when I put this lecture together last year, tried to find what we call gurney porn. In other words, different agencies, different providers who try different creative ways to spice up their gurney and make it look as neat as possible and as clean as possible and straight as possible. And these are just some of the examples that we found, and some of them are, as you can see, pretty damn creative. So, and on a personal level, I personally think that you can look at somebody's gurney, this is just me, but you can look at somebody's gurney in the back of the ambulance or when they're making up at the hospital and get an idea on the type of provider they are. I know there's no statistical correlation, but sometimes I think that if a paramedic is anal retentive enough to do their gurneys up, they're anal retentive enough in the rest of their care. It's just kind of it's just something I've noticed over the years as one of those little unspoken rules in pre-hospital care. You may or may not agree. There's another one. This is a pretty simple gurney. Notice it's flat. There's no sheets to bunch up, and that's where the idea of hospital corners came from, was to produce a wrinkle-free bed so that patients would not develop bed sores. So you can see the application there. But how many times have we seen providers that did pretty much, this was their level of attention to the gurneys that they made? If this is the type of thing that you roll into somebody's residence with, I would say that you're probably not providing them with good care in general. But in this case, we're talking about autonomic dysreflexia, nothing bundled up underneath them, and so on and so forth. Yeah, it's troubling. Be creative, have fun with it. As you can see here, we have very neat little examples of people. I like the towels, not just because they look neat, but I use towels all the time to both wipe up vomit and to give little old ladies a bonnet to keep their ears warm. Towels are really versatile. You can also make dolphins and snakes and other stuff for the kitties off of, so you get the idea. So, some other things to keep in mind is sit the patient up if possible. A little elevation of the torso goes a long way. If they start having exacerbation, and we defined what exacerbation is, the first thing is check the catheter, then check their position, check the belts and sheets, make sure they're not bunched up. They may not be able to tell you exactly what it is because their sensation is altered, but start digging for problems. Now, usually, the neat thing about autonomic dysreflexia is it resolves when you resolve the problem in most cases. So, look and make sure the catheter is draining fully, so on and so forth. If it is, if it isn't, then you fix it. Usually the blood pressure will come down. So that's good news. If it is refractory, you can't identify the cause, or it's something like UTI you can't fix immediately, and their blood pressure is above 150, and they're symptomatic. So that's the key thing, is they have to be symptomatic and their blood pressure above 150 millimeters of mercury systolic. Then we deal with short-term antihypertensives, nitrates, calcium channel blockers such as Procardia. You may not be familiar with Procardia. It's a drug we used to carry quite a bit in pre-hospital care for a hypertensive crisis, but we moved on to other things. But still used. I think Captopril is also used. A few other ones are also used in this role as emergent means of lowering the blood pressure. So nitroglycerin and nitro-paste, in general, if you have the luxury, I wouldn't even call it luxury, but if you have nitro-paste, that's what I'd go through first. Either 1 to 2 sprays every 5 minutes, followed by paste, or just straight to paste, 0.5 to 1.5 inches. Keep in mind, though, we talked about how spinal cord injury patients with an active sex life will often be on erectile dysfunction drugs. So it's not something we would normally think about asking, but you have to ask in this case. So, and I don't remember exactly what the study was, but there was some literature that showed that nitroglycerin was particularly effective, in instances where the AD was precipitated by a bladder problem. Matter of fact, they found it had a faster onset of action to reach safe target blood pressure than in other cases, and it took about 10 to 15 minutes. I'm looking at the data right here in my notes. About 10 to 15 minutes to reach the target normal blood pressure after administration of nitro. So it's not going to be boom immediate, but it should be fairly, reasonably quick, with about 84 to millimeter mercury drop in some cases. So this is another one, Procardia, and this is an example of a 10 milligram capsule of Procardia. I've seen them look different also, so this isn't 100%. So Procardia is a little bit unique. So there's a gel in there. This isn't a pill you get them to swallow. There's a gel in there. You poke it with a needle, or you have them bite down and chew it and get it underneath the tongue. So it's a sublingual administration, but it comes in a capsule. I know it seems kind of weird. It's a calcium channel blocker. We can bite and chew it, and then swallow the rest of it. So there you go. And it works really well. Captopril is an ACE inhibitor. It's a little bit different. It also can be administered. In this case, there's a sublingual composition. It takes about 15 minutes to onset. The dose is 25 milligrams. I personally have never seen this used, but I've heard of it being used. So it's not as common in the U.S. as it is other places, but there you go. Now, another possible use is beta blockers, such as metoprolol. It's more used in prevention for AD, or for AD that's refractory to other interventions. Really, if you carry beta blockers such as metoprolol or esmolol, which is a short-acting beta blocker, it's really a last resort after you've tried everything else. And the reason is because you can cause some beta blockade, but you still have alpha adrenergic effects that are running unopposed. So keep that in mind. It's just a last ditch, pulling out the hold, all holds barred. There you go. Another last ditch effort is possibly analgesia. If it's a noxious stimuli, maybe some opioids will provide some analgesic effects. Now, the literature on this is really kind of, I don't want to say sketchy, but dubious. It's not well explored, not well documented, and not definitive. But if you don't have beta blockers and they're refractory to nitrates, you don't have calcium channel blockers in this role, or they're refractory to it. And I do want to say real quick that when I talk about calcium channel blockers, and we talked about Procardia. Diltiazem, cardiazem, isn't good for this type of role. Yes, cardiazem can cause some hypotension, but that's not its primary action, where Procardia, Nifedipine, it is. And the difference is because there's multiple different calcium channels, and they block different ones and therefore cause different effects. So there you go. So finally, if you haven't gathered now, this is a complex medical condition, so read up on it. Read up on it, figure it out, and if you find something that I put up here that is not current, let me know when we do the forums on this, so we can all learn from that. Thank you very much, and remember, I plan on posting a forum for this unit that you can just ask questions. It's purely optional. So in addition to it'll be a discussion board, because that's the way that Moodle will handle it. But in general, it won't be a discussion board. It'll be that type of format where you can post a question and you can answer. So there's that. So thank you for your time. I appreciate it. And don't forget, there's a second lecture that we'll be doing shortly called Guillain-Barré. And I'll see you out there.